Welcome to this Beyond Zero e-learning module. This is part of the Wits RHI Advanced HIV and TB catch-up modules. This is module 4B, part of the PMTCT sessions, and we'll be looking specifically at lower respiratory tract infections and TB in pregnant women who are HIV positive. So this is a key slide when we talk about lower respiratory tract infections in women. This is the Savings Mother Report from 2011 to 2013, looking at the top causes of maternal deaths in South Africa. And what is great, over the last 8 years, we've seen a decrease of maternal deaths. So just from the last Savings Mother Report, that was the 2008 to 2010, there was a maternal mortality rate of 176 per 100,000. And this has dropped now to 154 per 100,000, but is still too high. And you can see there our top 3 causes of deaths are still non-pregnancy related infections, hypertension, and obstetric hemorrhage. And from the last report, the non-pregnant related infections has dropped by 12.6%, which is great. But it is still very high. So we can see in this last report, 34.7% of all maternal deaths was caused by non-pregnancy related infections, and 2/3 of those are caused by tuberculosis and pneumonia, and most of them would be HIV related. So already the critical commentary that was already from the previous Savings Mother report very much still counts, that most HIV infected pregnant women die from respiratory complications due to TB, PCP, and community-acquired pneumonia. And we have to really look for and manage these actively in pregnancy to save lives. So where do we start? Obviously, every single woman who is pregnant must be screened for TB at every single visit. And here they mention our HIV status, but obviously all women must be screened for TB. So great, we screen for TB and our mom is TB negative. Any HIV positive woman who is got no TB symptoms must be given IPT. So our TB screen does not mean taking a gene expert, it means a symptom screen. So the mom must have no cough, no fever, no night sweats, and no weight loss or failure to gain weight in pregnancy. And all of them we would start on IPT and pyridoxine. You don't need to do a TST to start the INH, but you do need to do a TST to know how long you're going to give the INH for. If the TST is negative, we're going to give IPT for 12 months. And this is mainly based on studies of women who were started on ART for the first time, but that's become a basic general recommendation for any woman who's on ARVs. But if she's TST positive, that means that she has latent TB, and a woman who is HIV positive and has latent TB is at a high risk at some point for that TB to wake up and become active disease. And so all of them qualify for IPT for 36 months based on the findings from the Botswana trial, which was a 36-month trial. There are contraindications for IPT, mostly to do with alcohol use or severe liver disease, which is rarely an issue in our pregnant patients. So hopefully by using IPT, we are going to prevent our women from getting TB. But what if you have somebody who is symptomatic? The TB screen suggests active TB disease, but you do not yet have confirmation. Very important at this point is we would not start her on ARVs if we've not first excluded TB. If she's already on ARVs, you would continue the ARVs and start the TB treatment. But in this scenario, we want to make sure we cover the baby while we wait for our TB investigations. We're therefore going to give our mommy AZT 300 milligrams BD as long as the HB is over 7. And then we would follow our normal TB investigation protocol, which in South Africa still means that you'll be sending a gene expert to try and make a diagnosis. So let's assume the gene expert comes back negative. We might even have treated with a course of antibiotics, and we're fairly sure that she does not have TB. At this point, we would want to switch our AZT to the fixed dose combination, the tenofovir, imidazolpidine, and efavirenz. And then a month later, you would screen for TB again. So the assumption would have been it would have been a bit of a flu or an upper respiratory tract infection, and we would assume that within a month's time she will be asymptomatic. And if she's then asymptomatic at that point, we would consider starting the IPT and the pyridoxine. Note, you're not going to start the INH just because the gene expert is negative, as she might have gene expert negative TB. But let's assume your gene expert comes back positive or your X-ray confirms TB. We therefore need to start our TB treatment. And at this point, we're going to continue the AZT for the first 2 weeks of TB treatment. After 2 weeks, we can stop the AZT and switch the mom onto the fixed dose combination. We're aware that there's a higher risk of IRIS by starting ARVs routinely at 2 weeks, and the mom has to be counseled about any possible worsening of symptoms or new symptoms during the coming months. And of course, we're going to have to do a birth PCR on that baby, as we know that these moms are also at higher risk. Once you've started a pregnant woman on TB, they need your normal good follow-up TB care. We're going to be doing our AFBs at baseline at 7 weeks and at 23 weeks. We're going to expect clinical improvement within 2 weeks, and we'll be monitoring for that. And we need to give extra nutritional support. Not only does she have the nutritional needs of being pregnant, but she also has the additional needs of fighting TB infection. But most importantly, we need to make sure that she receives integrated care. That means that preferably she will receive her antenatal care, her TB follow-up and medications, as well as her ARVs, all within the same room. And this will ensure that none of these treatment aspects will fall through the cracks during her pregnancy. So very important to note all of your information about the mother's TB treatment and history in the maternity record, because that'll be the only record the mom will have with her when she delivers, and the baby will need to receive prophylaxis for TB exposure. So I'm going to follow the guideline that's in the EDL. Please note that the advice given in the pediatric TB guideline, as well as in the text section of the national ARV guidelines, are incorrect. Firstly, we do not give BCG to any baby born to a mother with TB, and we have to check the baby for TB. You're first obviously going to look for your normal respiratory symptoms, especially tachypnea, but in babies often it's subtle, and hepatosplenomegaly would be very suggestive. An X-ray can give you a picture on whether there might be pulmonary TB, usually through hilar lymphadenopathy. And you could do a TST, although it would be questionable how much help it would be. It could be false negative if it's negative, especially if the baby is very sick. And if it's positive, it's telling you something that you already know, that the baby's been exposed to TB. If you are considering perinatal TB, you will need to send a gastric aspirate for a gene expert and a culture, and you would discuss that with a consultant. And these babies will receive normal TB treatment, usually 3 drugs for the first 2 months, your rifampicin, INH, and PZA, and then 2 drugs, your rifampicin and INH, for the remaining 4 months, using your EDL for the dosing. But if the baby is asymptomatic, no signs of TB, then we would want to give that little one INH once daily for 6 months. It's 10 milligrams per kilogram per dose, and there are weight bands within the EDL to make it easier for your calculation. After 6 months, you will stop the INH and recheck the HIV status of the child. If the HIV is negative, you can give the BCG at that stage. But if the baby is HIV positive, we will not give BCG as it is a live vaccine and there is a risk of disseminated BCG disease. I would like to go through a case discussion of quite a complicated patient who presents with lower respiratory tract symptoms. Miss LS is a 26-year-old woman who presents to casualty complaining of shortness of breath. It's been getting worse when she walks, but it's only been for the last week, so quite an acute presentation. And when you ask further, she also reports a non-productive cough. She's feeling cold and then hot, so possibly has fever, and she has a loss of appetite. When you take further questioning, you discover that there's no history of night sweats, no particular TB contact, but she's 24 weeks pregnant already with her second child. And at the clinic, she was already found to be HIV positive and started on the fixed dose combination quite recently. They've taken bloods for CD4 count and creatinine, but the results was not yet back. So we examine Mrs. LS and we discover that she's quite wasted. She's got generalized shotty lymphadenopathy, she's got oral thrush, and she's tachypneic with a respiratory rate of about 36 per minute. But when you listen to her chest, you discover that her chest is quite clear. So no wheezing, no bronchial sounds, but she looks very short of breath. Cardiovascular, she's fine, just tachycardic. And when you examine the abdominal examination, baby is fine, growing well, fetal heart heard. So what do we want to consider at this point? And obviously, if you're writing your HIV diploma, you will now write a comprehensive differential diagnosis. We're going to look at some of the key things we are considering. Infectious causes is by far the most common and by far the most worrying. So our first concern here is your normal viral infections, common also in our pregnant women. But the most worrying would be our bacterial pneumonias. And our HIV positive pregnant woman will have the same organisms as the HIV negative woman. Just watch out if they don't respond to treatment to consider, for example, your staphylococcus and to add in some of your proxycillins. TB is obviously very high on the list. And then depending on the CD4 count, we will consider our fungal infections. So if the CD4 count is very low, we will think about, for example, pneumocystis, Jirovecii pneumonia, histoplasmosis, even candida of the lungs. And also remember, with the very low CD4 counts, we will also think about more uncommon viral and bacterial infections, for example, your CMV of the lungs, herpes of the lungs, or something like MAC, your Mycobacterium avium complexes of the lungs. But we also have non-infectious causes, and some of them can be quite serious. LIP, not so common. Don't forget about pulmonary embolism, as we would get in our HIV-negative pregnant woman. Malignancies such as Kaposi's could be an issue with very low CD4 counts, and it might also be something like asthma or COPD, depending on their previous lung history. But if you have a pregnant woman in front of you who has this set of symptoms, what is going to be our top 3 concerns? And the first thing you want to think about is bacterial pneumonia. Not because it's the most common, but because it is what will kill her the quickest. Your bacterial pneumonias have to be addressed very, very quickly and picked up nice and early. And pneumocystis jirovecii pneumonia always have to be considered in our HIV positive woman. And our CD4 count will give us a clue there in whether that is part of our differential diagnosis. And then, of course, secondly, we will be considering TB. TB also relatively common, but we have a bit more time in being able to establish whether TB might be the cause. Of course, we're going to watch our response to treatment very closely, and only if they're not responding to the treatment of our pneumonias or our TBs do we want to start keeping into consideration some of the other causes as outlined in our differential. So shall we admit her? We can use our CORP 65, just leave out the 65 bit, which is our woman that's over 65 years old. Any patient with confusion of new onset, with a urea greater than 7, with a respiratory rate of more than 30 breaths per minute, or with a blood pressure that's dropping too low, we would consider those people for admission to hospital. We now want to try and differentiate whether we think this is pneumonia, PCP, or TB. And the first thing you're going to do when you're sitting there in casualty is do a pulse oximetry. It's partly important from a management point of view. If they're dropping their SATs, we need to get them onto oxygen. But PCP classically drops the SATs very early on in disease and will give you a little bit of a clue on whether we need to consider that. Chest X-ray to help us differentiate. Trying to get a sputum. This particular lady had a non-protective cough, so you might have to do an induced sputum. The sputum you're obviously going to send for gene expert, and also useful to do an MCNS if you do get something back. Bloods could be useful, full blood count, give us an idea of an infection. UNE certainly in somebody who is as ill as this. And LFT is a little bit lower down the list depending on what else you find on examination. CD4 count will be very important, and if they've done one at the clinic, to try and track that down, as it gives you an idea of the likelihood of something like pneumocystis jirovecii pneumonia. Blood cultures to help us for future in case she does not respond to treatment. And an LDH may or may not be helpful. An elevation of LDH can sometimes indicate PCP as well. So let's continue on what happened with our particular lady. We gave her oxygen immediately because we've discovered that the SATs is quite low. We sent her for a chest x-ray, and a chest x-ray reveals bilateral symmetrical interstitial infiltrates. The SATs on air was 82%, and when we called the clinic, we discovered that the CD4 count that they took a couple of weeks ago was 64. So when we look at all of this, what would be your number one diagnosis? Yes, in view of her reduced SATs, the minimal sounds on auscultation when we listen to her lungs, the suggestive X-ray, as well as the low CD4, we're going to consider pneumocystis jirovecii pneumonia iris as our first diagnosis. And the reason why we're thinking of an iris is that she's presented so soon after starting on ARVs. So she might actually have had the organism underlying, and this was an unmasking iris as her CD4 count was climbing. Let's just take a step back for a moment, because this could have all then been prevented if our patient had been on co-trimoxazole, and which of our patients should be given Bactrim, especially in view of pregnant women. And the guidelines is the same as for our adults. Any patient with a CD4 of less than 350, if they've got a prior episode of PCP, they might very well still be on Bactrim regardless of their CD4 count, and if they're stage 2, 3, or 4. But what about if she's pregnant? You see, if we go to our SAMF, we will discover that co-trimoxazole is category C in pregnancy. That means that there has been concerns in animal trials, or that we simply haven't got any information on pregnant women and Bactrim. The concern is about sulfonamides used during the 3rd trimester due to the risk of hyperbilirubinemia and kernicterus, but this is a low risk. And similarly, trimethoprim has a low risk of teratogenicity in animals because of its antifolate effect, mostly in the 1st trimester. So there's actually a specific recommendation with pregnant women saying that in a symptomatic HIV-infected woman, the benefits of giving co-trimoxazole outweigh the risks. And I'll just have an added caveat, is just to remember to give it with folate. And this is very important because non-pregnancy related infections is such a high cause of death in HIV-infected pregnant women. We need to make sure that we use Bactrim in those women where it is indicated. So let's look at our management of Miss LS specifically. And very importantly, we're going to put her on oxygen, and we have to put her on oxygen throughout our investigations while we get her actually onto treatment. And when we admit her, we might consider adding in bacterial pneumonia cover. I mean, this has been a nice, straightforward, beautiful case presentation where all the everything lines up beautifully. It's not always that clear-cut in practice, and it's sometimes very difficult to differentiate between a bacterial pneumonia and PJP, and sometimes they might even have dual diagnosis. For the PJP, we need to add in Bactrim, and very important, this is very high dose Bactrim, 20/100 milligrams per kilogram per day, which equates to about 16 tablets a day, and we normally give it in 4 divided dosages. So that's 4 tablets 4 times a day for 3 weeks. One can use IV if needed, but that will only be in cases where they can't actually take oral treatment because they are so ill. And you would see a good treatment response within the first 8 days. And matter of fact, by day 3 or 4, you actually want to see that your patient is getting better. And you'll notice that's a much longer period than for your bacterial pneumonias, where you would expect to see an improvement within a day. But it's slower than with your TB, where it would take a couple of weeks before you would know whether your patient is getting better. Bacterial pneumonia and PJP is quite urgent, and so if you are unsure of the diagnosis, you would start with these treatments first. TB, you could usually wait a week or 2 and see if they respond to this treatment and wait for your investigations to come back. An important consideration with PJP is the use of steroids. And in any patient where the SATs are low on room air under 70, you would consider using steroid treatment, and also consider it an HIV infection with severe disease. If you are going to use steroids, you need to use it as soon as possible. And here I want to emphasize that PJP has a high mortality, and early diagnosis and treatment is absolutely essential. When would you stop your Bactrim? Well, you would of course first complete your 3 weeks of treatment, and then the mom would need to go on to prophylaxis. That's your 2 tablets a day until her CD4 count is over 350 and 3 months apart. And an added to that is that we want to also then make sure she's obviously still on ARVs and that she's virally suppressed. If somebody is not virally suppressed, it's usually useful to continue the Bactrim as you would in somebody who is stage 2, 3, and 4. In summary, lower respiratory tract infections in pregnant women necessitate early diagnosis and management. Do not delay. And hopefully, by picking this up early and treating it well, we can decrease our maternal mortality rate in South Africa even further. Thank you. To complete this session, do remember to watch the other PMTCT sessions. There are 5 modules in total.